have seminars on a regular basis, so if you'd like to be more aware of what's going on at the Institute, please do leave us your email and let us know so that we can put you on our list. Also, we have a couple of workshops going on, and one beginning next week on the assessment and intervention for elder uses next week, beginning on a Wednesday. That's a workshop where you actually have to pay to join, but if you're interested in that, there are flyers on the cadenza just outside the room there, so just to let you know. On behalf of our director, Dr. Lynn McDonald, who can't be here because she's actually in a thesis defense just in the other room, welcome to the Institute. We are so pleased today to have with us Dr. David Conn from Baycrest and also right here from U of T's Department of Psychiatry. And Dr. Conn has been working actually with one of the projects that are housed here at the Institute, the National Initiative for the Care of the Elderly, which over the past 5 years has been developing tools to help practitioners and seniors and other people who are caring for elderly do a better job. So he's here to talk today about the Coalition's guidelines for seniors' mental health and the tools that they've developed along with NICE. And Dr. David Conn, I don't know if you know, but he's been head of psychiatry at Baycrest since, I think it was 1992?
92, yeah.
92. I'm sorry.
Till last month.
Right. And now he is the co-chair for the Coalition for Seniors Mental Health. So we're very pleased to have him here today and very honored. Thank you so much for coming, Dr. Conn. And
thank you.
We look forward to your talk.
Thank you, Susan. And well, good afternoon and welcome. Nice to have you here. And I gather we have quite a few people who are joining us online as well from different parts of the country, so welcome to you as well. And one thing I wanted to mention is that you can get my slides by emailing Nina Carlton, and I'll give you her email address. So it's Nina, N-I-N-A .Carlton, C-A-R-L-T-O-N, at utoronto.ca. That's utoronto.ca. So if you want the slides, please email Nina. So I think the other thing I wanted to mention is that I'll be showing a DVD in the middle of this PowerPoint presentation. Hopefully that will work both here in the room. And we know it's going to work in the room. I'm hoping it's going to work for the distance sites as well online. So let us know if you're having any difficulties. That will only be about between 5 and 10 minutes part of the presentation. So, yes, so I'm going to talk to you today about guidelines. First of all, I wanted to find out in the room, how many of you are health professionals? Quite a few. And students, undergrad or graduate? Okay. And any others who are just interested people who are here?
Retired.
A few retired people. Excellent. Okay, yes. Well, welcome to all of you. And the whole question of what guidelines are and how helpful they are, that's one of the things I'm going to be talking to you about. And specifically about guidelines that we've developed for health professionals who are working with seniors who have mental health problems. So I'm going to go through a brief introduction and talk to you a little bit about the Canadian Coalition for Seniors' Mental Health. And then start talking to you a little bit about how we move knowledge into action. And there's something called a knowledge to action cycle. And then I'll talk to you a bit about the actual creation of these 4 Canadian guidelines. And then the dissemination of the guidelines. So once you produce something, you obviously want to get it out there. But more importantly, how we try to implement the guidelines, that is, actually get them into practice. And finally talk a little bit about how we evolve the guidelines into guides, actually for seniors and their families. So that was a later stage of this project. And then we'll have plenty of time for discussion and next steps. Save your questions. Although if there's something you really want to ask me during the presentation, just put your hand up or yell out. I really don't mind. That'll be just fine. And And then we'll talk about where we go from here, because this is an ongoing project. We've been at this for a number of years, but any ideas you have, or if you want to work with us, or if you want to join our coalition, just let us know. And I will put up the website for the coalition at the end of the presentation as well. There's a lot of materials, including all of these guidelines and tools online. And just for the people who are on the web, people in the room got these handy cards, which are tools evolved from the guidelines on depression and suicide prevention. You can get all of these from the directly from the coalition's website. Well, maybe I'll say what that is right now. It's www.CCSMH.ca. So there's a lot of material there. So the Canadian Coalition for Seniors' Mental Health was created in 2002, so that means almost 9 years ago. It was initially in response to a symposium, a national symposium that we put on related to gaps in mental health services, specifically for seniors living in nursing homes, long-term care homes. And that was an area of interest that I've had for many, many years. And so a group of us started with support from the Canadian Academy of Geriatric Psychiatry to create this national conference. And one of the main outcomes from the conference was the need to create a coalition, a broad coalition, interdisciplinary coalition that would focus on this whole issue of how to improve seniors' mental health in Canada. So I've been the co-chair since it was founded, along with Ken LeClaire, who's from Queen's University. The mission of the coalition is to promote the mental health of seniors, Canadian seniors, by connecting people, ideas, and resources. So it's really the whole idea of forming a network, people working together from across the country, and really seeing what we can do by working together. And the key areas of focus that were actually established right at the beginning when the coalition was established were very broad. They included education, advocacy, promoting research and best practices, focusing on caregiving issues, and then also trying to look at human resources and capacity building, because that's a critical issue in all areas of seniors' health. And just to give you a sense of who's involved in this, this is the steering committee for the coalition. So it's representatives from each of these organizations that sit on the steering committee. So it's very broad. It has a lot of different disciplines involved, ranging from nurses, social workers, different physician groups, psychologists, and so forth. And these are just the people sitting on the steering committee. There are many other organizations that are also part of the coalition, members of the coalition. Membership is free, and which is actually a bit of a problem because it's hard to sustain an organization that has free membership. We've been lucky up till now to be able to get support from the Public Health Agency of Canada for various projects, and in the early years we actually got some support from pharmaceutical companies who gave us some money just to get it going, which was very helpful. But in recent years it's all been really government funding. And more recently, we've had a couple of projects from the Mental Health Commission of Canada. So this is something called the Knowledge to Action cycle, and it was produced originally by Ian Graham. And the main point I want you to look at here is that in the middle, you see an inner circle with a triangle in the middle, and this is how we create knowledge. So how do we actually create knowledge? Well, hopefully it starts out with original research, although there are many types of research, both quantitative and qualitative, but ultimately we put everything that we know about a topic together to create and to synthesize this, and ultimately to determine in clinical practice what's the best recommendations that we can make for a given clinical problem. Let's say depression. So what do we know about depression? Well, this little card here would tell you a bit about assessment and treatment, a sort of summary of the key points. But to get this card, this is 100 years of research, all compiled, integrated, and ultimately it takes a lot of expertise to create this. So there's the whole process of moving research into some sort of summary of what the recommendations are, and then some sort of product that we can use to influence and advise clinical practitioners. So that's all very well, creating the tool or the instrument, but then how do you actually get it into practice? So the outer circle here is really talking about the whole process of moving the knowledge into action. And that really involves a very complex process. But the one thing that I would say is that I think there's a strong belief among those who are specialists in guidelines and best practices that ultimately the implementation of guidelines is always local. So we can produce national guidelines, or international guidelines for that matter, but when it comes to actually doing something with them, it happens locally. It happens in a particular office or in a hospital. It doesn't happen nationally. So it means that it's up to the individual practitioners, clinicians, to determine what to do with these tools. And so that's where we have to actually think very carefully about how do you actually not just influence, but actually potentially change the behavior of a clinical practitioner. And this basically looks at the same thing, this image here, but this is more focused actually on guidelines, and it speaks to how one might create a guideline and then move it locally. So you'll see number 6 there, which is the green box there, talks about how you would adapt a guideline for local use. And one of the references that I'll put up at the end of this talk is specifically focused on that whole issue of how do you adapt a national guideline for local use to get it actually into practice. So ultimately the goal of guidelines is to improve the quality of care and potentially to close a measurable gap in care. So that would suggest that that the writers of the guideline would produce something that's usually a bit utopian. Usually is, the very best standard of care in the ideal environment where you have unlimited resources. In fact, that's one of the criticisms of guidelines, is that they tend to be they tend to set the bar so high that a lot of clinicians might say, well, this doesn't make sense. We don't have the resources for this or that. For example, just a simple example, if you look at the recommended treatment for depression, it's usually a combination of medication and psychotherapy that's most effective. But in real life, most people get, and I'm talking about serious depression here, not mild depression, but most people get the medication, but they don't get the psychotherapy. Why? Resources. There's not enough therapists in the community. And so it's all very well for the guideline writers to say everyone should get a combination, or in some cases just psychotherapy, because many people respond well to psychotherapy. But if the resources aren't there in the community, especially outside of urban areas, then they may be idealistic guidelines, but not that easy to put into practice. So closing a measurable gap in care, in order to assess this, we have to know what that gap is. And therefore we have to know about service delivery, we have to have data on this, we have to know what the gap is in care. And even in working locally in your own practice or your own hospital, do you actually know what's going on? The only way to figure that out is to do audits, and that takes work, and it takes people to do that. So now an individual practitioner can assess themselves to see, am I practicing according to the guidelines? They can do that, and we would recommend that. That's a way of developing yourself personally and figuring out whether your practice, what you do, is standard of care. But guidelines have been described as one of the most promising and effective tools for improving quality. What about physicians? What do they think about guidelines? Actually, one of my colleagues, Sid Feldman, who told me that family doctors often develop what's called the gag reflex when they receive another guideline in the mail or any other way, and GAG stands for Got Another Guideline. So, and the problem is that as a family practitioner, you're inundated with the latest guidelines from this association and that body and this body, and you're just trying to do your job, So, but there was a survey of 3,000 physicians, Canadian, with a very good response rate, remarkably good response rate. I don't know how they managed to achieve that, but about half of the physicians said they used guidelines of one sort or another, at least monthly. They said that they had more confidence in guidelines that were produced by medical organizations. 50% strongly agreed that they're a convenient source of advice and good educational tools, but there were concerns such as loss of autonomy or rigidity of guidelines, and the preferred formats were short pamphlets, brief summaries, or possibly journal articles and pocket cards like the ones we handed out here. So they like things that are easy to use. You only have so much time for studying and reviewing, so they want them to be handy. The Canadian Medical Association talks about the challenge of clinical practice guidelines, and these were some of the things that they outlined in a document on guidelines. Some very basic stuff. They said that people may actually disagree on what is high-quality care. The complexity of clinical practice may be difficult, may make it difficult to capture in a guideline. Study results may not easily translate into daily practice, so that's sort of looking at pure research versus what's doable in daily practice. There may be conflicting guidelines, so you might get different guidelines from different organizations that actually suggest doing things differently. Disease-specific guidelines may provide conflicting advice for patients with coexisting diseases. So I think that's an interesting one, in that guidelines tend to focus very much on one specific condition or disorder or disease, and then don't think about the fact that most people don't just have one problem, they have multiple problems that interact and make things more complex. As I mentioned before, the implementation of guidelines depends on a range of factors, often beyond the control of the individual clinician. Keeping up guidelines requires ongoing work and resources. I'll mention that later. And recommendations of the guidelines may be inappropriately biased by the composition of the group preparing them. So, for example, if it's only a group of physicians, that could bias the conclusions, or if it was just a group of nurses, for example. And cost is a factor. Obviously, it takes time and energy and ultimately money to put together guidelines. So I mentioned our coalition was developed in 2002, and 3 years later, we were awarded funding by the Public Health Agency of Canada, Population Health Fund, to develop guidelines. And the goal was to lead and facilitate the development of evidence-based recommendations for best practice guidelines in 4 areas of seniors' mental health. And I won't go into the details of this rather complex slide, except to say that it's a complex process creating guidelines with lots of people involved and boxes and literature reviews. And the good thing is we were able to pull together from across the country for each of the 4 guidelines experts, a group from multiple disciplines, with co-leads, and people who were willing to give a lot of time and energy into doing this. And ultimately, not only did we use the basic literature, but we used any existing guidelines from other countries that we thought would be helpful as well. We did find some that we referenced in our guidelines and certainly borrowed from. So the scope of the guidelines was to be multidisciplinary, to focus on older adults, to think about the problem across a continuum of healthcare settings, all the way from primary care, community, to hospitals and nursing homes. We were asked to address variations in practice across Canada, to involve consumers in the process, and to identify gaps in knowledge, in other words, where future research might be required. And of course, the principles were that the guidelines should be based on the existing evidence, they should be broad in scope, practical, clear, concise, and readable, consumer-friendly, and they should address things such as cultural diversity, caregivers, gender, special population groups, so pretty broad mandate. there are different systems for categorizing evidence. So we used one from Shakel. And basically, the highest, number one standard of evidence would be evidence from a meta-analysis of randomized controlled trials. So if you were, let's say, looking at the pharmacological treatment of depression, you would look at all of the trials that had been carried out in older adults, and then see if there was a meta-analysis, which would be a study combining the results, and look at the results of that. And then the least useful evidence comes from expert opinion. That is, a group of experts, or one expert says, it should be done this way, because I've had a lot of experience, and I think that counts for a lot. And so we don't completely discount that, but we don't give it a lot of, we don't rate that kind of evidence very high. And then there are various categories in the middle that would come from other types of studies. And then looking at the quality of the evidence, then we also would move to for each recommendation to give it a strength of recommendation, and that's mostly based on how good the research is, the evidence supporting it, but it also involves other things. So, for example, there might be good evidence that one treatment is excellent, but it could be that it's a very dangerous treatment, in which case you might rank it lower down in terms of the strength of recommendation. So these were the 4 sets of guidelines that were created. One was focused on delirium, which is an acute confusional state. Again, all focused on seniors. Delirium is a huge issue, particularly in hospital settings. Delirium usually occurs when people are ill, and they're often related to an underlying physical condition, such as an infection, or sometimes they're drug-related, or in fact related to drug withdrawal. So, critical issue, very dangerous condition. People who are delirious need excellent medical care, and for that matter, excellent psychological care as well, because it's a very distressing state. The second set of guidelines focused on the assessment and treatment of depression, which of course is a huge issue in all age groups, but certainly a big issue for older adults. The third focused on the assessment and treatment of mental health issues, specifically in long-term care homes, and that is remains a really significant and serious problem. And the last was focused on another serious problem among seniors, and that is suicide risk and preventing suicide. So it took about almost a year and a half to develop the guidelines and to complete them, and they were released in May of 2006 and disseminated then across the country and internationally. So this says, type that up, make 10,000 copies, and send them to all the important people in the world. So that's a sort of, that's one approach to guideline dissemination. Now, sorry, I apologize, this should be colored, this slide, but it actually, this was as of early 2010. This was the number of, the distribution of our guidelines and knowledge translation tools. And as you can see here, the numbers are quite high. So, for example, the number of hard copies of the guidelines that were sent out for suicide was almost 20,000, and for the others ranging around 12 to 15,000. And then if we look at hard copy versus electronic copies, we're ahead in hard copies, but the electronic copy numbers are also very high. So a lot of them went out there to all sorts of people. And there was a lot of interest internationally as well in this set of guidelines. The International Psychogeriatric Association put them on their learning portal, and they were the only guidelines that exist on their website. So, and we had downloads from more than 60 different countries. And this says, are these just guidelines? Are they actually new policies? Okay, so, and this is a very important cartoon, I think, because it kind of hits the nail on the head. So you can send out a guideline, but unless it's actually a new policy, a lot of people might ignore the guideline. So for the average practitioner, like, what do you do with this? You get this guideline, and these documents were actually pretty big. So this is the suicide one, so it's big. There's a lot of recommendations in there, pages and pages and pages of background and references, and we do distill the recommendations into clear, easily readable recommendations. So you don't have to fish your way all the way through the document. They are clearly outlined, but there's a lot of them in all of these guidelines. There's lots of recommendations. So it's tough for clinicians to know what's most important, what do I need to change, and actually one important point, I don't know if it's on a subsequent slide, it might be, but the strength of evidence for 80% of the recommendations in our guidelines was ranked low. In other words, the research wasn't all that great. So a clinician might say, well, okay, you're recommending this, I know you're a national body, but the research doesn't back you up that well. So that is a problem. The provincial medical bodies like the College of Physicians and Surgeons of Ontario, they have statements about guidelines, and what they say is that the guidelines don't set the standards. They inform the standards, but they definitely do not set the standards. So that's important. So, okay, so we sent them out, thousands of them, all over the place, right? And then we sort of sat back and said, oh, this is great, we've done a great job, right? So the problem is that you don't really know if that achieves anything at all, really. And there's quite a bit of evidence to suggest that simply disseminating a guideline document doesn't actually achieve that much. You might feel good about doing it, but you don't necessarily achieve that much. I spoke to a colleague from the US who developed some guidelines, and as we were developing ours, and I said, and they came up with a very nice document. I said, so, what have you done with it? How are you using it? How's it being utilized across the country? What are you doing about the next stages of implementation, etc.? And his response was, well, we published it in JAGS, which is a very highly rated journal. But and I said, okay, and what else? And he said, no, that's all we're doing at this point, and that's doesn't really achieve that much. So we got lots of feedback from frontline staff that the guidelines were useful, good synthesis of information in the current state of the art, very useful as teaching tools, but they did say that they were too long to use in day-to-day practice. They were cumbersome, and they wanted something that was easier to use. So we went back to the Public Health Agency of Canada, and we said, okay, we've done what you wanted, we've reduced the guidelines, but we need to test them and to move the project further into practice. And so they agreed with us and gave us more funding to move into the knowledge translation or implementation phase of the project. And so we got funding for 7 implementation projects, and I wanted to tell you a bit about a few of them, just to outline what they were. So the first one was a collaboration with the National Institute for Care of the Elderly, which is NICE, and Lynn MacDonald is the director of NICE, as well as being the head of this institute where we're sitting right now. So this is a great partnership, and you'll actually see that the pocket card on depression has both the coalition and the NICE logo on it. And so this was a joint effort, and part of the implementation of this was to have educational sessions with family physicians and family healthcare teams using both in-person and online education. The second project focused on suicide risk and prevention, And we'll talk quite a bit about this one because I'm going to show you part of a DVD that was produced as part of the toolkit for this particular project. And so leaders in Ontario, that's Martin Heisel from University of Western Ontario, Martha Donnelly from BC, and Sharon Moore, who's a nurse from Alberta, partnered to lead this particular project. In Nova Scotia, there's a network for seniors' mental health, and they decided to use these by having educational sessions for staff across Nova Scotia using interactive video conferencing. And they devised some really interesting tools to bring the guidelines to life in the clinical sense. And I'll show you that in a minute. Then there was a group who liked the delirium guidelines, but they worked specifically in end-of-life care and palliative care settings, and they wanted to figure out whether these guidelines worked in that setting. And so they've been working for several years now to adapt the original guidelines specifically to end-of-life care. And their separate guideline document is just about to be released. It will be available on our website if you have an interest in that area. Another project was to actually survey the Canadian Academy of Geriatric Psychiatry members. These are counted as geriatric psychiatrists, so obviously an important group in terms of caring for individuals with these disorders, problems. So we surveyed them to find out, okay, well, what do you think about these guidelines? Are you using them? How are you using them? So I can show you a little bit about that. And then at my center at Baycrest, we decided to implement the long-term care guidelines on 3 units in our nursing home. And I'll tell you a bit about that project because that became really interesting and fascinating. And the last project was a provincial project, also trying to implement the long-term care guidelines in 16 different nursing homes in Ontario. So one of the things that we did was to try to produce tools. We took the feedback seriously about these being too big, and then so we ended up trying to distill the basic information into pocket cards. And so we produced pocket cards for all of the guidelines, and then to widely distribute these. And practitioners like these, students love these as well, because you got all the information you need in a little card. So I think that's been an important process. This was a second card that was produced in the depression project, looking at whether patients might be at high risk of depression. And that's just a quick description of the joint project with NICE. English and French, so virtually everything we produce is available in French as well, of course. And these are all available online in French. And the suicide prevention group decided to really put together an elaborate toolkit, and they received some funding from through CIHR, actually got an award called the Betty Havens Award in Knowledge Translation, and used the funding from this to develop this toolkit. And then our coalition as a whole received the same award this year for this giant project. So inside the Suicide Prevention Toolkit, there are a number of things, including the original guidelines, a pocket card, a facilitator's guide, so how to work with staff, with professionals around this issue, and then a DVD. So I wanted to show you a little bit about what's on the DVD, because I think you'd really appreciate seeing it. So what I'm going to do now is play a little bit from it. Hopefully that'll work.
So why did we decide to make a video on the issue of suicide and suicide prevention in older adults? We know that the issue of suicide among seniors is a growing one. For the last 100 or so years, really ever since mortality statistics have been collected, we've known that older adults have among the highest rates of suicide of any age group. Certainly worldwide, data from the World Health Organization tells us that people in their 60s, in their 70s, and beyond have among the world's highest rates of suicide. We know as well that we're on the brink of a period of time when we're going to have a large population of older adults in this country and really throughout the world. The baby boom cohort, people born between 1946 to 1964, will soon be reaching their senior years, age 65 and beyond. We know that this group will be older adults for the next 40 to 50 years. We also know that baby boomers have had, over the courses of their life, higher rates of suicide than their parents' and grandparents' generations. So we're on the brink of a period of time in which we're going to have a large group of people with high risk of suicide coming into a period of their life when suicide risk is higher. Even if the rates of suicide among seniors remains the same, the number of people who may very well die by suicide will increase tremendously. We've developed this video in order to begin addressing that problem. This video is a companion piece to the guideline recently published by the Canadian Coalition for Seniors' Mental Health on the assessment of suicide risk and prevention of suicide among older adults. This video segment highlights many of the key messages of that guideline. In accordance with the guideline, we've developed the character of Mr. Jim Johnson, a man in his 70s, retired high school teacher who recently lost his wife following a bout of ovarian cancer. We've created the character of Mr. Johnson because he highlights many of the key risk factors for suicide among older adults. We know from mortality statistics that people who are white in this country have higher rates of suicide than do non-whites. We know as well that suicide rates increase with age across the world. Certainly in Canada, men in their mid-70s and higher have suicide rates that are more than double the nation's suicide rates. This particular video is not intended primarily for family members or for the general public. It's intended for care providers, for frontline health care and mental health professionals who may come into contact with older adults on a day-to-day basis and may in fact be the first people who are approached by older adults at risk for suicide. By providing an example of some of the issues surrounding suicide risk in later life, ways of detecting risk and intervening, and ways of beginning the dialogue with an older adult who might be at risk, we hope to influence care provision for those people at risk.
Good morning.
Good morning.
Mr. Johnson, I see you missed your appointment last week.
Yes, I'm sorry about that. I just wasn't feeling up to it.
Not feeling too well lately?
Oh, usual for an old guy. Bad joke, huh? I am having a bit of back pain. I'm sorry about being late. My car's in the shop. I had to take 3 buses to get here.
Oh, why? What happened to your car?
Oh, nothing major. I missed the entrance to the golf course and dinged up the front end. My daughter's making a federal case out of it. And the worst thing about it was the jarring my back took, and of course dealing with the insurance company.
My dad is going through a rough patch these days, emotionally. But he doesn't talk about that. Never has. Dad just hasn't been the same since Mom died 2 years ago. She suffered terribly with ovarian cancer for a few years. But Dad was great. He took her to all of her doctor's appointments and for chemo. He even gave up his weekly poker game with his buddies just to spend time with her. Maybe he gave up too much.
Has anyone else looked at this yet?
Well, no, not really.
Okay, up, down.
Ever since I got up the next morning, my back's been killing me. I really do need some relief.
Okay, I'll write you a prescription for something that should work well. Now, you cannot take any alcohol when you're taking these painkillers, all right? Okay. Are you having any other related problems?
Well, I haven't been sleeping well lately. I just can't seem to get comfortable.
Okay, I'll give you something for that as well. That'll help. We'd better take an x-ray too, just to be on the safe side. And let's schedule an appointment for next week when the pictures come back. Right? And until then, just take it easy. No heavy lifting, lots of bed rest. All right? Good. We'll see you next week then.
Older adults who die by suicide very commonly see their physician in weeks to months before doing so. In fact, 70 to 75% of seniors who take their lives have seen their family doctor within the previous month. This suggests to us the extreme importance of making clear to those who work in family medical practices and primary care clinics the importance of their role in potentially detecting suicide risk in older adults, making referrals to other mental health specialists, or intervening themselves. The research...
So, this case continues with various developments and individuals involved, and culminates actually in a suicide attempt. And there's a lot of lessons to be learned along the way. Any thoughts about what you saw so far? Yeah.
Well, just how the doctor's always giving medication,
Right.
and that's not getting to the root cause, and that actually could cause him to get worse into a suicidal
Right.
state.
Yeah. He was also prescribing him sleeping pills,
Yes,
right?
yeah.
Which might not be the best thing to do. Yeah.
I'm not so sure how many doctors are aware of community resources. My experience is, and because the resources change so much, like the funding changes, so there's a new name, and they just can't keep up.
Absolutely. It's a real challenge.
Yeah.
Yeah. And certainly, as you know, as the case progresses, the doctor clues into the depression part, and does pick up the fact that this gentleman may be a suicide risk, and starts to give him advice and tells him about the helplines and so forth. Any other thoughts?
It does make an issue about the fact that the family physician in the ideal setting is that they have continuity of knowing you before depression, and also that you have more of time. That was a pretty slow family physician visit. Usually they say what do you need, what's going on, and you have probably less 10 to 15 minutes in and out.
Yeah, it's pretty
and
fast.
Some of them even have a thing saying each visit only has one reason.
One problem, right? Yeah, don't tell me you're suicidal. I've got dealing with your back pain this time, right?
So you're not going to talk about what might be going on, these sort of what I call vague questions. It is, you need medication, you have this. They really want to know what they are going to do. It's not really looking at a history of taking of all the issues.
Yeah.
As well, he seems to have cut out everything that he used to enjoy.
Absolutely.
Definitely is
Increases.
worse things.
It's very bad. Yeah, he's got a lot of signs of depression there, even without going through the classic signs and symptoms. Yeah, but the challenge for the family physician is to deal with all of these different problems in a short period of time, given the demands on them. That being said, I think family doctors have gotten a lot better actually at picking up depression and at least starting treatment. So, the only other segment I wanted to play for you, just there are different sections to this DVD, including the whole case, and then some separate sections looking at risk factors and warning signs. And then completely different is this segment here, which is an interview with a survivor, two actually, whose relatives committed suicide. Maybe it's chapter 1.
Which suggests that collaborative care in developing this video piece, providing education for healthcare providers, frontline providers, and education providers as well, we've decided to incorporate the extremely important piece of involving survivors of the suicide of older family members in order to begin to address the extremely important point of stigma. Stigma is an issue that affects mental health care provision, seeking of mental health care, and especially can impact today and tomorrow's generation of older adults who might feel stigmatized by the difficulties that they are experiencing and by the need for mental health care. We've decided to address this directly by involving family members in order to show that any one of us can experience these difficulties and can have a family member struggling with them. By opening this up, by opening up the discussion, by making it acceptable to talk about suicide and suicide risk, we can begin to raise the veil that's been surrounding suicide, a veil of secrecy.
My involvement began a number of years ago when both my parents died by suicide. It was a suicide pact. They were 68 and 69 at the time. And it came as a complete surprise to everybody in the family. None of us had any inkling that there were any issues or anything that they were going through at the time. They were both very healthy people and had retired and were, had been looking forward to retirement. So we all lived in different parts of the country, and the first that we heard about it was being notified that they had died. So it was a big shocker to everybody in the family because we hadn't in any way seen it coming.
It was actually my paternal grandmother.
So anyway, I think you get a sense of how useful this toolkit is, and obviously it's dramatically different to have a tool like that. It brings a case to life, get to see what's happening with the different family members, the health practitioners, and who are linking back to the recommendations in the guidelines, and then even to talk, to hear from some individuals who've had family members committing suicide. Very powerful, I think. And so I think this group did an amazing job at creating a toolkit that could really, in a sense, make the guidelines much more meaningful, particularly as a teaching tool. So, by the way, the whole video is available online at the Coalition's website. Perhaps I could just ask anyone who's at the distance sites or by their computers if they have any questions. Have you gotten any questions yet? No? If anyone has a question, please, they just type it in, right?
Yes.
And we'll respond to your questions, and certainly towards the end we'll leave time for your questions as well. I mentioned the group in Nova Scotia who had a lot of education modules and teaching sessions, and they devised a series of case examples based on each of the guidelines that brought the case to life, and that went through different situations where the health practitioners have to make decisions, and then each decision is linked back to what's in the guidelines. So this was an example of one of them. It says here you've been asked to see Mrs. D. Prest, 78-year-old woman whose husband died suddenly of a heart attack 1 month ago. Her family doctor reports that since the death, she has appeared sad-looking, with low energy, trouble falling asleep, and has spoken of feeling his presence, hearing his voice call her name, and she's accompanied by one of her daughters. And immediately you're asked, okay, what do you think is going on? Is this a serious depression with psychotic features, or is it a bereavement, a normal bereavement, or something called an adjustment disorder, and so forth? And the case sort of evolves with lots of time for discussion along the way. So again, a very powerful educational tool. And this just gives details about the dissemination in Nova Scotia, the number of people who attended the sessions, and ultimately at the bottom it says that the majority of responders said that they were now more likely to screen for delirium, depression, and suicide risk factors in the elderly, and were more likely to refer to the guidelines and the depression brochure to help answer other questions they might have. One of the other projects was to survey the members of the Canadian Academy, and almost half responded to the survey, which is quite good, and they were asked how they use the different guidelines. Many of them use them for teaching or training. Some use them to solve clinical issues. Some use them to review and evaluate their current practices. Some simply use them as curriculum materials. Others use them as part of a research project, and so on. So it gave us some sense of how the guidelines were being used. 56% said that the guidelines resulted in a change in their practice, and then in terms of the degree of change, mostly rated that 3 out of 5. Some said that the guidelines basically represented how I practice already, or that they support my practice but didn't change it. 39% said that there was a commitment from their organization to disseminate the guidelines. 33% said that they had organizational commitment to actually implement the guidelines. 57% used them in presentations or lectures, and a similar number used them while working with students, trainees. And this was rating the usefulness of the guidelines, so most people rated them as either mostly good, actually, a sort of 4 on a 5-point scale. And then I want to mention the project we carried out at Baycrest. This is where we took these guidelines and really decided what we could do at the bedside in the nursing home. So we got a group together who were interested in this project, and we wanted to try and figure out, okay, here's the guideline, what are we actually doing, what's the gap? And so we had focus groups to really try to understand how the staff were approaching mental health issues. We had focus groups actually with some of the residents, the actual individuals living in the nursing home, and with families. We did a chart audit. We participated in interprofessional team rounds to observe what was going on, and then went back to the guidelines and tried to figure out where was there a gap. And different groups had different thoughts about that and wanted different things. So we heard from clients and families, particularly from families, that they wanted better communication and more staff training, especially around managing behavioral issues, which is a very challenging problem in nursing homes. The personal support workers wanted more team communication and to be more meaningfully integrated into the team. Interesting. The team itself wanted to improve their knowledge and skills, and we also found that the teams in general were not using a lot of formal assessment tools. So we had a steering committee, a clinical implementation team, and we used something called participatory action research, which is a collaborative approach to research which directly engages and involves all stakeholders, and which is why we did the focus groups with so many different individuals, not just the clinical team. Participatory action is defined as a continuous cycle in which insiders and outsiders together decide what needs to be researched, design the research, and collect the necessary information, which is then put into practical applications or used to identify new research ideas. The key here is meaningful participation, so getting everyone actively engaged and involved. And there is a suggestion that if you involve people meaningfully, you're going to ultimately have more successful implementation and improve sustainability, which makes sense. I must say that when I went into this project, I was not figuring out that we were going to use this approach. I thought we were going to basically pick good recommendations and figure out what the teams weren't doing well, and then basically say, you know, you need to do this, this, and this because you're not doing it. It says you. So very sort of top-down approach. But then after we all started meeting, and it became apparent that if you really want to change practice, you have to work much more from the bottom up than from the top down. So this was the format of the project, quite complex, but we were lucky we got a grant to do this from the Government of Ontario, and basically we did collect data. It was really a mixture of a qualitative and quantitative research project. And we had 3 pilot units. One is called a behavioral support unit, one a mental health unit, and one a cognitive support unit focused on dementia. All the staff were involved, including volunteers. We also tried to measure outcomes amongst 37 residents. That was the number we were able to get consent from. And all the families were invited to participate in priority selection. Priority selection is we did something called dot voting, which is basically we involved everyone in the project to determine which recommendations we should focus on. And people were given a set number of dots, and they were able to vote on a wall. And we ultimately decided by dot voting which of the key recommendations in the guidelines we were going to really focus on. So family members were included and were given dots as well. So ultimately, the determination, because these are very wide-ranging guidelines, the ones for long-term care, and we decided to focus on behavioral issues, on staff education, and teaching the staff approaches, strategies, techniques for dealing with behavioral problems using non-pharmacological interventions. So we developed some training modules for staff. We had a huge training day where virtually everyone on these units came. We used some funding to backfill the staff so other nurses could come in from other units. There was discussion about the whole issue of team rounds and the fact that personal support workers who at the lowest rung on the ladder weren't going to the team rounds because they were too busy doing hands-on care, and it was determined that they should, at least representatives of the PSW should start attending the team rounds. There was also the introduction of something called huddles. Huddles are when teams facing a problem meet as a group briefly, 10 minutes, 15 minutes, around a specific problem. You know, they do it on the football field, they do it in the military, and now it's becoming more apparent that they can have a role in clinical practice. So we started to introduce huddles, and they became very popular and useful. So the methodology I mentioned was quantitative and qualitative. So we did some use certain instruments, including something called the NPI, that's the Neuropsychiatric Inventory. And we also wanted to look at the staff themselves. So we used a tool called the PACE, which looks at work-life satisfaction. And interestingly enough, when we actually looked at the data, the main findings were more around the staff than around the residents. So there was actually an improvement in statistically significant improvement in job satisfaction, feelings about leadership, and a sense of available workplace resources. So that was important. When it came to the actual data for the residents, there was a trend to somewhat decreased agitation, but not statistically significant. The focus groups after implementation suggested that the staff reported more confidence, more feelings of worth and being of value on the team, that they had a greater understanding of mental health issues. They felt better about team communication and teamwork. There was acknowledgement they felt of violence issues in the workplace and action plans for safety, and feelings of better support from colleagues, the team, and the unit managers. And most importantly, there was the emergence of leaders on the units, not from the managers, but from frontline staff, many of whom actually became champions of the project. So I won't go through these. I think that summarizes what I just said, basically. Here's an example, though. This was from a poster presented at a conference on the huddles, which was really something that evolved out of the project. No one had a clue that we were going to end up using huddles. But the really nice thing about this project is, you can't read it, but the first two authors of this poster were an RPN, a registered practical nurse from one of the units, and a PSW, personal support worker. So again, I think that's an indicator of how far this project really went, which is very nice, because normally staff like that wouldn't get to participate in research, or let alone present something at a big conference. So. And then there's the whole issue of sustainability. So far, a lot of these things that we developed in the project are continuing on those units, and actually the whole huddles thing has become, our research institute at Baycrest has a clinician scientist who took up this and decided we should do some really serious research on huddles, and so that's developing as a whole other sort of development from this project. She's since moved back to New York and is now doing some of the huddles research in New York, so it's really moving. So, and the last thing I wanted to mention is that it's all very well to have all these tools for health professionals, but we also felt it would be useful to produce some guides for seniors and their families. So, so we developed these guides, which reflect what's in the guidelines, but they're translated into useful, easy-to-read information that that we produced again for seniors and their families. So. I think this was another really good spin-off from the whole project. And ultimately, one way to influence practice is to educate patient, family, who then go to their health practitioner and say, "Well, it says this in the guideline, doctor." So I think certainly consumer education and patient education has dramatically changed in recent years. Obviously, with so much information now available at one's fingertips, on the net and on your iPhone. So that's changing healthcare dramatically as well, I think. So just coming back to how one implements guidelines or best practices. So there's something called a Cochrane review. That's basically a review of all of the existing literature. And some years ago, Cochrane review provided this information that when it comes to implementing guidelines, dissemination and didactic presentations are generally ineffective in terms of implementing guidelines. Things that are more effective are to have health practitioners carry out audits, or people carry out audits of health practitioners and then provide confidential feedback, which says, this is what the guidelines say, this is what your practice is. Take a look, there's a difference. You need to get buy-in, you need to have local opinion leaders and champions. As I said before, things have to become local to really move into practice. Consumer education has been found to be helpful because it can influence practice as well. And using reminders, on electronic health records, you can put in reminders and checks. And education itself can influence the implementation of guidelines. And there is an approach called academic detailing, which is interesting, which is, the pharmaceutical industry developed over many years an approach of how to influence family physicians, right? So they get into your office, And usually they have like 2 minutes or 3 minutes, and they've got to get their message across really fast. So they have, something glossy, something that's very clear to read, with the reference and the link, and so what some academics have done is said, that's actually quite a good approach. Let's duplicate that in terms of getting other messages across to health practitioners. So I'm going to stop there, and these are some people who need acknowledgement because they did fantastic work on this. Kim Wilson is the current executive director of the coalition, and she's giving a course at the Institute at the moment on mental health and seniors. And Sherry was the project director. Faith Malik was the previous executive director. Jennifer Markley was a student who worked with us. And then all of the Guideline co-chairs and committee members and all of the coalition members, partner organizations and networks. Simone Powell from the Public Health Agency of Canada, who was very, very supportive. And CIHR for their recent award to the coalition. And for the Baycrest group, these are all individuals who did tremendous work on the project. And a couple of references here. One is a very good article from the Canadian Medical Association Journal last year on adapting clinical practice guidelines to local context. And the other is a book on this topic written by 3 different editors, including Sharon Strauss, who's here in Toronto and a guru in knowledge translation. Sharon is the head of geriatric medicine at the University of Toronto, but also works at the Li Ka-shing Institute in St. Mike's. And this is a very good book on the topic. And that's the website for the coalition. And I think at that point I'd really like to open it up to questions from far or near. We've covered quite a lot of territory, but I hope I've given you a sense of both the strengths and potential weaknesses of guidelines. And they're helpful to improve practice, but they're not sufficient. You need much more than just creating a guideline. It's really the whole process of moving the guideline into practice that's critical. And I think we're still learning at the moment. This is actually early days, but it's a critically important thing if you think about it. These days, everyone's talking about from the bench to the bedside, meaning, the research bench, the lab, to the bedside, or the point of care. Not always the bedside, hopefully it's an office or the community, but how good are we at really translating what it is we know into what happens at the point of care? So I'll stop there. Thank you very much. Maybe I'll start. Did you get any questions yet online?
No. I've told them that they can feel free to ask questions, but no one has said anything yet. Okay.
Well, if you're online, I'd love to hear from you. Actually, love to hear where you are as well, which part of the country. So, but how about here in locally? Any thoughts, general thoughts, or questions or comments? Yeah.
Hi, Dr. Conn. I have a question on what are your thoughts on seniors transitioning from independent living settings to more institutionalized care settings, and whether this is contributing to higher levels of depression, and what can we do as healthcare professionals in better preparing them?
So the question, just to repeat it, was the challenge of transitioning from independent living to some sort of institutional setting. And of course there's a whole range of different types of group living situations. They range from retirement homes all the way through to nursing homes, of course, and assisted living in between. So it's a complex question because the vast majority of people want to live independently, want to live in their own homes as long as possible, retaining as much independence as possible. And some people are willing to accept a fair amount of help in order to do that. So community resources become critical, having home care services. Here it's the CCAC that provides services, which, while being helpful, are often inadequate. So, the actual amount that we spend on community care versus institutional care is very imbalanced. And if you think about what people really want, the fact of life is that that we spend most of our healthcare dollars on people who are extremely ill and in the very last months of life, you know, and no one would say necessarily we shouldn't spend that money, but the reality is that our system has developed that way, where we pour more and more money into hospitals. And although the healthcare reform has always said we want to spend more on the community, and there have been movements to spend more on the community, it's been pretty slow going. So I think that's part of the answer is we want to keep people at home as long as possible, but the reality is that for some people it gets to the point where it's very difficult to remain at home, and they're going to need some setting where there's more care available. Some people accept that, and others don't accept and find it very difficult, and find adapting to an institutional setting can be difficult. And you know, there's a whole movement now to make nursing homes more home-like, and there are different approaches that are used to do that. There's one called the Eden alternative, for example, and you know, the idea is smaller homes, more animals, more plants, more intergenerational programming, more links to the community, less rigidity in terms of institutional regimens and so forth. And so we can try and do all of those things with some success, but it's still a challenge, and you're still living with other people, and you've got to adjust to that. So some people definitely find it very difficult. You've been living independently your whole life, and then all of a sudden, you know, you're thrust into a room with someone else, and you've got to try and adjust to their schedules and so forth. So I think we can, I think, first of all, try and keep people at home as long as possible, then try to make our long-term care homes as humane as possible, and that can make, I think, the adaptation somewhat easier, but never easy. And there are high rates of depression as people move into nursing homes. So we have to recognize that as well, and then respond to that.
You made mention that there are community organizations. One I had formerly worked at was Sprint, Senior
Sprint,
People's
yeah, great
Resources
organization.
in North Toronto.
Yeah.
And maybe if, just an idea is try and get them involved in some of the activities, and then slowly integrate them into the home so that they're a little bit more social.
Yeah.
And then
Yeah.
get them into the home, and they get involved in the activities in the home as well.
Yeah, and some people will end up, you know, as a transition, may go to a day center, a day program, and that can be very helpful, and can sometimes actually delay the movement into a nursing home.
You're so right about community. At the end, we're looking at the end product instead of the prevention.
Mm.
And I happen to live down in condo land, and people, I mean, there are some really good condos with a lot of activities, but where I live, they don't, well, they have the fitness things, you know. And kids get their parents to buy a condo so that they'll get the condo when their parents die. That's my version. And then they're isolated. And particularly the women, they're scared to go out at night. They watch the television, they see the knifings, and they're very, very shut in. And then they don't get to know the resources. Well, our community centre has got a Horizon grant. Watching the difference has been amazing. They provide food. Doesn't matter, coffee,
it's a good
cookies.
start. Yeah, yeah.
And people who are anxious will come out to one event, and then you see them joining a second event. And the staff are really skilled that they've hired. They'll phone the person if they haven't seen them for 2 or 3 weeks. So this person feels needed. So that's the prevention that I don't see our society doing.
Yeah, I agree completely. It's an awful lot of very isolated, lonely
Because the more you drink,
people.
the more you drink.
Yeah, yeah. Yes.
Hi, so we actually have 3 people asking questions online.
Okay.
The first question is, hi Dr. Conn, I'm from the geriatric mental health outreach team out of Scarborough Hospital. Do you know of any plans to develop guidelines to help us managing residents with personality disorders, especially in LTC? Thank you.
So the question's about guidelines for managing individuals with personality disorders. That's a great question, and no, I don't know of any guideline project specifically on personality disorders, but I certainly acknowledge that's a critically difficult problem, and staff in long-term care often spend a lot of time and energy trying to cope with individuals who have personality disorders. Not the classic thing we think about. We have a book that's called Practical Psychiatry in the Long-Term Care Home, a handbook for staff, and that's published by Herbert and Huber. And that has a pretty good chapter in it about managing individuals with personality disorders in long-term care homes. So you might want to reference that. If you want to email me, I think I could probably send you that chapter. So it's dcon@baycrest.org.
So second question. Second one comes from Pan Thomas. Can you comment on what I've read in recent articles that screening tools for depression and or suicide risks are helpful, but that sensitive interviews and perceptive interviews are more important? In brackets, he said, I like screening tools myself.
Yeah, I think screening tools are just that. They're just screening tools. And the idea of a screening tool is it tells you there's a problem here, pay attention, wake up. So this person could be depressed or they could be suicidal, but that's just the beginning of the assessment. And a good clinician will then start to figure out what's going on and take a full biopsychosocial approach to the problem. And particularly when it's talking about suicide, you have to be a good clinical interviewer, and you have to be comfortable with the topic to be able to discuss it. And actually, one of the strengths about with the DVD is it does go into that. And there's some seasoned geriatric psychiatrists on this, and others who talk about the challenge of interviewing and some useful basic questions like how do you start asking someone if they're suicidal. So a basic question like have you ever felt that life isn't worth living is a very good introductory question. But I agree that with the person asking the question here that screening tools are useful, and they at least make sure we don't miss things, but they don't substitute for a good clinical interview.
And the last question is from Jeanette Robertson. So she says, hello, we were wondering if after conducting your surveys, did you notice that the guidelines seem to be better received in specific areas, for example, geographic location or service providers?
If they were better received, is that right?
Or better received in specific areas.
So I don't think we really have that kind of analysis. We do have data on where they were disseminated across Canada and which provinces have asked for more or less of them. But we don't really have data on the uptake, so I think that's a very interesting question. But no, unfortunately, I don't have data on that.
Thank you.
Okay, thanks. Nice to have questions from folks online. Thank you very much. Maybe time for one more question or comment?
We have a bit of an observation question, or it'll be all inclusive, really. I noticed on the research that you had, you were talking about the RPNs and the PSWs not feeling like they're part of the team. And in terms of suicide prevention, the RPNs and PSWs, quite frankly, would be seeing, residents or patients more frequently than anybody else.
Absolutely.
Providing daily care. So I just thought it was interesting that, and I wonder if there's any sort of way to kind of get the assessment and the tools to them, because they're the ones who are going to be able to recognize nonverbal signs of suicide. Nonverbal signs, somebody who's not saying it, but showing behaviors that would suggest that they're depressed and potentially suicidal.
Yeah, that's a great comment, question, really, because I think it's true that the PSWs and the RPNs do all of the frontline work. They spend all the time with the residents, and what few RNs we have are so busy administering medication and documenting. They don't spend actually that much time, and the physicians fly in and out, of course. And so we do rely on the frontline staff to really tell us what's going on, and they need to be sensitive to these things. So that's why we spend quite a lot of time trying to have direct education with all of the staff, discussing strategies with them, and we reckon that's really where you get bang for your buck, so to speak. If you want to be effective, you've got to get to the point of care. So the point's really well taken, and it's a real challenge because in most organizations and institutions, there's precious little time made available to educate frontline staff. They're so busy with basic care, so we have to get better at that. And we have to devise different strategies for educating staff who don't have a lot of time. So at the bedside interventions, nurses teaching nurses, and they're not going to attend a 1-hour lecture in the middle of the day. So.
There has to be an attitude change, in my opinion. The people at the top think they know it all, and that's my opinion.
Well, thank you all. Thanks for your comments and questions.